Welcome to our Structural Heart Disease podcast. My name is Feroz Mahmood. I'm the Director of Cardiac Anesthesia at Beth Israel Deaconess Medical Center. In the first of the series of these podcasts, we will be reviewing a case undergoing mitral clip procedure that required a precise location of the mitral regurgitation jet, where the patient had suboptimal 3D images, and therefore we had to resort to certain other maneuvers to resolve and solve this problem. The panelists participating in this discussion are Dr. Michael Herring, Dr. Ruma Bose, Senkap Sehgal, Aidan Sharkey, and Dr. John Mitchell. Enjoy the podcast. So the case history is that we have a patient who is 78-year-old male with history of coronary artery disease and multiple coronary stents placed in the last 5 or 7 years. Recently he had a history of numerous episodes of heart failure. He had a detailed workup at the hospital that revealed severe functional mitral regurgitation. Considering all his comorbidities, he was considered prohibitive risk for surgery and was scheduled to undergo mitral clip. We'll keep the history and physical examination short so they can focus on the problem at hand, that was the intraoperative or the peri-procedural transesophageal echo examination. So these are the first or the three initial images that we took in this patient. This shows a mid-esophageal four-chamber, a little close-up of the valve, and a mitral regurgitation jet, which demonstrates it's going a little bit more posteriorly directed. As you can see, there's this strut cord in this anterior leaflet, which is sort of attached close to the margin of the anterior leaflet. This was of very serious concern to us because we thought that if we were to do something, it might get entangled in this cord and at the same time cause the cord to rupture and have a flail anterior leaflet. So, Aidan, what do you think? Would you be concerned about the position of this strut cord, and would you sort of have a different clip strategy, which means would you choose an extra wide clip or extra, the not so wide clips for this one?
Yes, I mean, the cord is definitely, an issue because you don't want to end up with, a flail cord, as you said, was the kind of the worry here. So I think in this situation, having the ability to grasp each leaflet separately, might be an advantage. And having a wider clip as well might be an advantage as well, yeah.
And also, if you see that the posterior leaflet is significantly retracted and kind of curled over, this means that a smaller clip may not be able to get under it physically, and you may have to kind of bunch it up with a larger clip. So there was a little challenge in its anatomy as we look at it. Do you agree with that?
Yeah. I mean, it's very retracted there, so I can definitely see problems with the shorter clip of grasping that leaflet, which again, being able to individually grasp the leaflets might be of benefit, with the newer devices.
Okay. So what is being discussed is that the morphology of the leaflets, specifically the lengths and the degree of retraction of the leaflets, can be used to select the type of clip to be used in this clinical operation. For example, the G4NT and G4NTW are 4 millimeters and 6 millimeters wider than, but at the same time, the newer versions, that is G4XT and XTW, have a larger and a longer length of the arms. So therefore, longer leaflets can be grasped, and at the same time, retracted leaflets can also be easily grasped in these larger clips. Since it was already established that the patient had severe mitral regurgitation, our initial exam was focused in localizing the point of origin of the mitral regurgitation jet. Looking at this transcommissural view in which we can see the posteromedial and the anterolateral commissures at the same time, it appears that the larger area of flow convergence is between the A2 scallop and the P1 scallop on the right side, which implies that the majority of the regurgitation is coming from the lateral side of A2, P2, or on the anterolateral commissure. What do you think, Aidan, Mike?
Yeah, I mean, looking at that video on the right, you can definitely see, the Pisa formation there is right at the kind of the P3 scallop area. So I mean, that's where I think the main or the first target should be, and probably where the first clip should be directed towards.
Mike, do you agree with that?
Yeah, I agree. Even I can see that jet has a much larger, and it's got a larger vena contracta, and unless you're at a plane with the jet on the left, so you're not seeing the whole thing. In fact, the one on the right seems a lot worse.
The learning point of this activity is that for a comprehensive interrogation of an MR jet, an area of flow convergence, flow contraction, and flow expansion has to be seen in the same frame. In the absence of simultaneous visualization of all these three components, neither the origin nor the severity of the MR jet can be conclusively diagnosed, as is the case with the jet seen above the posteromedial commissure in this video loop. Next, we perform the monoplane examination of the mitral valve that consists of progressive advancement of the TE probe with scan plane at 0 degrees with and without color flow Doppler from the A1P1 to A2P2 and finally A3P3 scallops. Interestingly, it shows that most MR is actually coming from the A2P2 and A3P3 scallops, contrary to what we found in the transcommissural view. Mike, would you agree with that?
Well, I mean, I suggested it, so I
you agree. You agree with this thing.
What about Suncup?
Is Suncup here?
I agree.
Okay.
And John Mitchell's here too.
Perfect. Aidan, what do you think?
Yeah, no, I think you can see a nice pizza formation there. So I think we're definitely beginning to see, the origin of the most significant regurgitant jet at this location.
Sankup, what would you think about this contradiction?
I think, in my opinion, this is obviously functional in origin, and we've all been there where the jet origin. It's important to again do a monoplane examination to determine the origin, because the jet does diverge, and it can appear to be coming from a little bit more medial or lateral location than the origin itself, or just splits into two and can be misinformative.
Great point. Also, it is important to remember a very important consideration when interrogating functional or ischemic mitral regurgitation is that it often impacts the posteromedial scallop of the mitral valve, and that's P3 retraction is the commonest finding. And functional mitral regurgitation coming out of the anterolateral commissure is not impossible but highly unusual. What do you think, Sankup?
Absolutely. To that point, I was also thinking that we presume we're in the plane, perfect mid-commissural plane, but we know that P1, A2, P3 can quickly become P1, P2, A3, with again that translation motion of the probe, a few millimeters here and there. So it's again important to keep in mind that where you are with the commissural, the two-chamber. These are not quite the textbook perfect views. So keeping eye on the exact location is the key.
The first teaching point from this activity is the utility of the monoplane examination of the mitral valve, in which the transesophageal echo probe is gradually advanced in the esophagus at 0 degree scan rotation from the anterolateral commissure between A1 and P1 to A2 and P2 and progressively to A3, P3 scallops of the mitral valve and interrogation of the posteromedial commissure. It removes the ambiguity obtained with oblique views and accounts for sometimes the translation motion of the heart as well as respiratory variation. Secondly, while we heavily rely on the transcommissural view to diagnose identify the precise location of the regurgitation jet, it is obvious that because of the translation motion of the heart or slight motion of the probe from left to right, there can be significant variation in the scallops that are displayed, as was the case in this specific situation. Based on the available information, particularly the monoplane examination, it can be safely concluded that the major part of the regurgitation jet starts from the medial side of the A2-P2 scallop and between the A3 and P3 scallops.
Yeah. And I mean, just going back to your point, I mean, when we look at a 2D examination, we make a lot of assumptions that we're in the correct plane. So I mean, I think not, I think this all needs to be confirmed, and this is where the value of 3D comes in to precisely locate. So I think that would be the next step, is to do a 3D examination of this on this patient.
Next, we obtain a 3D en-face view of the mitral valve with color flow Doppler information. On the left, the video shows the entire extent of the regurgitation jet from the line of coaptation through the entire left atrium, whereas the graphic on the right, the grayscale has been maintained where the color flow Doppler information has been cropped down through the origin of the jet from the line of coaptation to show its broad nature and its precise location of its largest extent. In the middle is a graphic for a visual feedback to identify the precise location of the MR jet. Senkap, would you please interpret this image for the audience?
Yeah, so it looks like you're cropping it down to the origin, so you're cutting off part of the atrium and trying to get down to the area of the vena contracta. I mean, here that's a diastolic part, and then so you're seeing origin of the jet again in that A2, A3 region. So again, more towards the posterior medial commissure.
Based on the available information, it can be safely stated that majority of the regurgitation is coming from the middle of the valve between A2, P2, and then posteromedial commissure, that is A3 and P3. And there's a small regurgitation jet between A1 and P1. And the apparent contradictory information was obtained because of possibly an oblique section of the valve, which made it sound like most of the regurgitation was coming from A1 and P1. What do you think, Aidan?
Yeah, no, I would agree with that. And I mean, the image on the right, you can see the real elliptical shape of the jet, which again, is in keeping with, ischemic regurgitation. So, that image on the right really highlights it's a broad-based jet, elliptical in shape, coming from, the medial aspect of A2P2 into A2P3.
There are 3 important learning points from this exercise. Number 1, there should always be a backup imaging plan when suboptimal imaging is encountered in a patient undergoing a percutaneous structural heart disease intervention. Number 2, whereas 3-dimensional imaging is ideal, 2-dimensional imaging can provide valuable insights into precisely locating structural heart disease derangements, particularly so in mitral valve. And number 3, the echocardiographer should have a detailed and a thorough knowledge of cardiac anatomy and its display to customize the echo exam to the anatomical peculiarities and to localize structural derangements with a degree of precision, as was the case in this patient. I hope you like this exercise, and stay tuned for the second part of this podcast. Thank you.